Hello, and welcome to this episode of In Discussion With from Pharmacy Update Online. Today, I'm talking to Neil Powell about evidence-based approaches to penicillin allergy delabeling. Please, could you start by telling us your name and position and giving us a brief overview of your current role?
Neil Powell, and I'm a consultant antimicrobial pharmacist at the Royal Cornwall Hospital. So my role, I do 2 days a week for the NHS, and 3 days a week I am an NIHR and Health Education England funded clinical doctoral research fellow. So the 3 days a week I'm doing research, which we'll talk a bit about during this, and the 2 days a week my title is Associate Director of Antimicrobial Stewardship, so I have a responsibility within the organisation to ensure that the hospital is delivering on our antibiotic stewardship programme of work. And also, outside of the hospital, I have a responsibility across our integrated care board to ensure that antibiotic prescribing is appropriate in primary care and also across the community hospitals.
You are the recipient of a research grant from Health Education England and the National Institute for Healthcare Research, and this is for a study concerned with removing erroneous penicillin allergy labels. And this is what I want to explore in this interview. But first, what's the issue here? After all, penicillin allergy labels are a good thing, aren't they?
So we used to think that, and they were put about, they were put into electronic health records and prescribing systems as a safety feature to try and prevent us from giving patients with penicillin allergy records penicillins. But the unintended consequence of that is that lots of people who don't genuinely have allergy records, who are not genuinely allergic to penicillin, are denied penicillin. So penicillin allergy records are common, and 15% of hospitalized patients have a penicillin allergy record. But less than 5% of those people with an allergy record are genuinely allergic to penicillin. So we're denying penicillin in a lot of people. So we're not giving people penicillin with an allergy record, good safety thing, but actually in being risk averse like that, actually we're causing more harm, or we're realizing we're causing more harm. So we still need to make sure we don't give penicillin to those sort of less than 5% of genuine allergies, but by not giving penicillin to the sort of 95% of people who can, we are potentially causing harm. And that harm has been quantified in lots of observational studies, and it includes things like, by using alternative antibiotics, we increase patients' risk of treatment failure and mortality. We increase their lengths of stay. We increase their risk of side effects, and actually the list goes on and on. There's lots of potential harms. So this is all fairly new. We sort of over the last 10 years or so recognize that penicillin allergy records mean that we don't use penicillins in those patients, but as a consequence of that, they are getting potentially inferior treatment with negative consequences. So that's the issue.
So how is it that someone ends up with an erroneous penicillin allergy label?
Well, the first thing to say is most people, and I think it's around 70% of people who have a penicillin allergy record, acquire that in the first 3 years of their life. So it comes about during childhood often. And the reason people have these records there are quite a few reasons. So one quite common reason is childhood rashes. So if you have a child with a sore throat or a upper respiratory tract infection, they're often caused by viruses, sometimes by bacteria, but those infections can cause skin rashes. So what used to happen was, and hopefully we do it less now, but what used to happen was children come to see a doctor or a healthcare worker with a viral infection, get given antibiotics, penicillin for that viral infection, and then they break out in a rash a few days later. And that's often pinned on the penicillin, and actually it was the infection, the viral infection, that caused the rash. That's the common one. Other ones are, people have diarrhea, nausea, vomiting, so side effects that get mislabeled as allergy. It used to be any consequence of of penicillin, whether an allergy or side effect, just got called an allergy. So it's a misnaming of what it is. Sometimes the penicillin can cause a skin reaction, a mild skin reaction often. And what we sort of see is that without continued exposure, with the period of time between the penicillin-induced rash and when you get re-exposed to it, most people don't get the same rash again. So it could be penicillin, it could be T-cell mediated skin reaction, but actually the immunity is not remembered and it doesn't react in the same way. And then some people do have proper, IgE mediated reactions, anaphylaxis, angioedema, caused by IgE, but that penicillin specific IgE wanes over time. So they might have reacted to it 10 years ago, but after 10 years, 80% of people lose their IgE to penicillin, so they don't then react in the same way further down the line. So there's some of the sort of reasons that I know of as to where it comes from, when in your life you acquire this label, and the sort of things that result in an incorrect allergy label.